Let us now study with the topic of coronary artery disease and the different thrombolytic agents and recent advances in the management of coronary artery disease. Well, coronary artery disease is the biggest burden of whole over the world. After road traffic accident, the most common cause of sudden cardiac deaths are none other than coronary artery disease related events. It not only includes coronary artery disease, I should place it as in cardiovascular diseases. The cardiovascular diseases include stroke, of course, cardiac related manifestations in the form of coronary artery disease, heart failure, and apart from this, the peripheral vascular diseases. So, among this, our interest of topic or topic which we want to focus from an exam point of view, which will also help you in the clinical life also in the future, is none other than coronary artery disease. So let us study coronary artery disease and various thrombolytics therapies, various new managements, various new indicators which will help us to come to a final diagnosis and give the treatment. So let us study the coronary artery disease. Like we know, first let us go through the various different parts of the coronary artery disease. Friends, we have got a coronary artery which is, if you see the cross section area, this is the aorta which is got in the aortic valve. This is a two cusp here shown, and if you open up further, the three cusps are seen. The one cusp, the one aortic cusp which is towards the right and gives the opening to the right coronary artery is known as right coronary cusp. Right coronary cusp which gives to the opening of the right coronary artery. The another one towards the left side, and it is little posteriorly placed, is the left coronary cusp. So this is the left coronary cusp and it gives rise to the origin of left coronary artery. The another one coronary artery which is again little posteriorly is known as non-coronary cusp or non-coronary cusp, because there is no any coronary artery arises from it. There are very normally but very rarely certain anomalies can give rise that right or left coronary artery can arise from this non-coronary cusp, but those are very rare conditions or anomaly. If you see these cusps, if we shown here very beautifully, these cusps are like an kangaroo bags where this coronary artery arises. These cusps are forms the sinuses. They forms the coronary sinus of Valsalva. Friends, there is one more coronary sinus in our heart which is placed most posterior structure in the heart, as it carries the deoxygenated venous return of middle vein, great vein and smaller vein into the coronary sinus, draining into the right atrium. Please never ever confuse with that coronary sinus with those coronary sinuses. These are coronary aortic coronary sinus of Valsalva, which gives right coronary artery from right coronary sinus of Valsalva or right coronary cusp, the left coronary cusp and the non-coronary cusp. If you see in depth, usually, now this is the right atrium, this is the aorta which gives rise to the opening of the left ventricle, this is the mitral valve and this is the left atrium. So right atrium, right ventricle, tricuspid wall, left atrium, left ventricle. So if you see this, the right coronary sinus are thin built, they are relatively thin, and they may, because of acute rise of any afterload to the aorta. I mean to say, if you uplift any dumbbell or if you lift very heavy weights, you may immediately increase very high afterload in this aorta. In certain individuals, this right coronary cusp, which is already physiological weaker as compared to other coronary cusps, they are like paper thin, and in certain cases or certain individuals, they are having congenitally little aneurysmal formation. Certain patients, if they immediately lift heavy weights or dumbbells, or they push a cart with a very high pressure, this will result in the sudden rupture of this coronary sinus. This sudden rupture of the coronary sinus will lead to the direct communication of the aorta to the right ventricle. This is known as rupture of sinus of Valsalva, and the most commonest is right coronaricus rupturing into the right ventricle. Okay, so I repeat again, rupture of sinus of Valsalva. So this is a very important concept one should remember. You might be knowing a various Indian famous weightlifter who immediately lifted the weight, and after few seconds immediately she fallen down and she got collapsed, but she never woke up. The postmortem report shown that she had a massive rupture of this right coronary cusp into the right ventricle, resulting into the sudden high pressure exposure of aorta to the right ventricle and acute right heart failure. Acute right-sided heart failure. Why right heart failure will happen? Because the aorta has so much high pressure of 120 by 80 as compared to the right ventricle having only just 30 by 12 mm of Hg. This acute sudden rise of such a high pressure won't be tolerated by the right ventricle, and it gets arrested, and thus the patient succumbs to death. So remember, this is very important to note. Rupture of sinus of Valsalva is most commonly right coronary cusp rupturing into the right ventricle, and one of the very important congenital pathologies. Coming to the next part. Before going to the next part, I want to focus it once again. This coronary blood flow fills maximum during the diastole, and thus that's the reason, friends, the coronary artery blood supply is during the diastolic phase. In fact, it is always the difference between the aortic diastolic pressure and the difference between the left ventricular diastolic pressure determines the transcoronary pressure, also known as the perfusion pressure or coronary perfusion pressure. So friends, if normally the transcoronary perfusion pressure, that's known as transcoronary perfusion pressure. What is this? It is the difference of diastolic blood pressure of aorta versus diastolic blood pressure of the left ventricle. Left ventricle. We know that diastolic blood pressure normal in aorta is 80, while diastolic blood pressure of left ventricle maximum 12. So around 68 mm of Hg is the diastolic perfusion pressure of the coronary. So please mark it as an important. This transcoronary perfusion pressures are very important, and that is the reason, friends. I'm sorry. That is the reason, friends, you have to maintain the diastolic pressure of aorta also 80, and simultaneously the LV should also have been maintaining maximum this. Only then anything which is more than equal to 55 to 60 mm of Hg is sufficient enough to perfuse the coronary arteries very well. Anything below this will produce an anginal symptoms. Let's take an example of aortic regurgitation. I repeat, in aortic regurgitation, particularly severe aortic regurgitation, the diastolic pressure of the left ventricle is of the aorta is too low and that of the left ventricle is too high, resulting in compromisation of the left ventricular coronary artery filling pressure, and this will result in angina, which we do see commonly in aortic regurgitation. So please make a note of this, the transcoronary perfusion pressure concept, which has not been explained clearly in any books, but it is one of the very important in the practical life. Okay, coming back to the anatomy, we do know that the coronary arteries, there are two coronary arteries, one coronary artery which is running across between, this is the right atrium, this is the right ventricle, and this is the left ventricle. So you can see this is the interventricular septum normally, which divides the left ventricle and the right ventricle, right atrium and right ventricle groove, the runs is the right coronary artery. So right coronary artery runs across the right AV groove. So right coronary artery runs into the right AV groove. Right AV groove means right atrioventricular groove as demonstrated here, and then it goes posteriorly. The left coronary artery, which arises posterior to the left ventricle as shown here, will come posterior to the aorta and the pulmonary artery, and then will come out, and the left coronary artery will divide into two parts. Left anterior descending artery, which will go round down as shown here. So these, it will go down across the interventricular septum, left anterior descending artery. While the another artery which runs parallel to the, like how the right AV groove, similar left AV groove, this is the left atrium. So left atrium, left ventricle groove. So left circumflex artery, that is left circumflex artery runs between the left AV groove. Okay, left AV groove. So left circumflex artery and the right coronary artery, they are almost misnomer, or they are almost equivalents on either side of the heart. So these are the very three important coronary arteries. Let me make it very clear again. First, very important, the right coronary artery. Then there is a left main coronary artery. This left coronary artery is also known as left mains coronary artery. So this is a very important thing. This left anterior descending and left coronary artery divided into left anterior descending artery and left circumflex artery. So this is a very, very important concept that one should know, and has to be very well understandable from this point of view. Now if you see the right coronary artery, if you go into details and see, so I hope so you have understanding this. The right coronary artery, left coronary artery, left mains coronary artery divided into left circumflex and left anterior descending artery. The left circumflex artery goes and supplies the posterior surface of the heart. So left circumflex artery supplies the posterior surface of heart or left ventricle, while left anterior descending artery supplies the anterior, the apex and little lateral part of left ventricle, while the right coronary artery supplies the right ventricle completely and certain times inferior wall of left ventricle. I repeat, right coronary artery completely supplies the right ventricle and little bit the inferior wall of the left ventricle. So right coronary artery, left coronary artery, right ventricle, inferior wall of the left ventricle, the left coronary artery, LAD, that is left anterior descending artery, left circumflex artery. This all supplies the left anterior descending artery supplies the anterior wall of the heart, very important, the apex of the heart, very important, and the left lateral wall of the heart, very important. So these are all the three important surfaces of the heart which is supplied by the left anterior descending artery. Is one of the very important artery. So if you see, this is the left main coronary artery which will divide into the circumflex artery this way, and again it will go as a left anterior descending artery here in this way. This left anterior descending artery is a very important artery, and this supplies the major part. This left anterior descending artery, this is the left circumflex artery. So left anterior descending artery supplies the anterior wall of the left ventricle, anterior wall of left ventricle. It supplies the lateral wall of left ventricle through diagonal branches. I'll come to it, diagonal branches. And it also supplies the apex part, very important part, the muscular part, apex part. So the left anterior descending artery is a very important into this. If anywhere blockage happens here, like this way, it's called as a proximal left anterior descending artery block, you will have a massive myocardial infarction, which will compromise the anterior wall of the left ventricle, lateral wall of the left ventricle, and also the apex. This will result in the sudden death of many patients. Okay, so complete occlusion of the left anterior descending artery, that is proximal left anterior descending artery, can lead to the take of life of many adult patients. This artery is hence known as widow marker artery. I repeat again, proximal left anterior descending artery is known as widow marker artery or widow maker artery. So again, so this is the left mains coronary artery, left main coronary artery, also known as left coronary artery, which divide into left circumflex artery, which is going into the left AV groove, and the one going into anterior interventricular septum is known as left anterior descending artery. It has got a proximal blockage. If it happens somewhere here, it will reach to the sudden arrest, and that will result into the massive myocardial infarction. Hence, this is a very important concept to understand the importance of what is widowmaker artery, what is the blockage, what are these things. So, is it so clear, everyone? So, this is a very important concept of the coronary arteries. So, basically this, I won't go into the details of the coronary anatomy as I don't wanted to tell, but only one thing about the bundle branches what I wanted to say is the bundle branches, what I wanted to bring out the notice is that about the about the bundle branch blocks. We know that, you know that we have got the blood supply to the bundle branches. Okay, blood supply to conducting system of heart. So we know that there is something known as SA node, which is the pacemaker of the heart. Then there is known as AV node. Then there is bundle of His. It divides into the right bundle branch and left bundle branch. This left bundle branch has got two fascicle. One is anterior fascicle and left is the posterior fascicle. The anterior fascicle and the left posterior fascicle. So, SA whole of the conducting system of the heart, SA node, AV node, right bundle, left bundle, all this fascicle, maximum or whole conducting system is supplied by the left anterior descending artery. Okay, whole of the conduction system of the heart is supplied by the left whole of the conduction system of the heart is supplied majorly by the right coronary artery, supplied by the right coronary artery, except bundle branches. Whole of the conducting system is supplied by the right coronary artery except the bundle branches which are supplied by the left anterior descending artery. So, your right bundle branch, left anterior descending artery, your left bundle branch, left anterior descending artery, fascicles, SA node, AV node is right coronary artery they supply, and bundle of His is both by LAD and the right coronary artery supply. Okay, in short, to remember friends, whole of the conducting system of the heart is supplied by the right coronary artery except the bundle branch blocks which are bundle branch which is supplied by the left anterior descending artery. So friends, again I repeat here, so SA node supplied, AV node supplied by the right coronary artery, bundle of His majorly by LAD but certain times right coronary, right bundle and left bundle predominantly supplied by the left anterior descending artery. So this is a very important one, should remember that whenever SA node gets blocked, think of right coronary artery blockage is there. Whenever you have got a right bundle branch block, left anterior descending artery block is very highly suspected. So these are the things you should know, and we will study this is again details when we study the ECG part, friends. Okay, now let us come to the very important part after this, the how does the coronary artery blockages happens. Okay, so let us me first discuss me into the details part of it, and then there is a very important thing what I'll suggest you about is this. So let us study the coronary artery disease. Okay, it's a coronary artery disease. Coronary artery disease, it is also known as ischemic heart disease. Okay, ischemic heart disease is called. So coronary artery disease and ischemic heart disease. So it can be two types. It can be obstructive coronary artery disease, which is very common. Obstructive coronary artery disease, that means proper blockages are present in our coronary arteries. I show you very fantastically. And the another one is despite non-obstructive. One is non-obstructive coronary artery disease, also known as myocardial infarction of non-obstructive coronary artery. ठीक है, it is basically micro circulation blockage, not the main blockage. Remember, whatever we have studied this coronary arteries in detail, these coronary arteries are nothing but these are the epicardial arteries, and there are small branches which is not visible practically. They are very small branches. They go and perfuse like this one. These are small branches. These small branches are known as intramyocardial vessels or resistant vessels, and those are associated with the blockages. This type of blockage or coronary artery disease is known as microcirculation blockage or coronary artery, is also known as non-obstructive coronary artery disease or MINOCA. It's a new terminology. Please make a note of it. A very important concept. Let us study the very interesting, that is the obstructive coronary artery disease. Okay, so in obstructive coronary artery disease, if the coronary artery blockage is just less than equal to 50%, okay, such patients are asymptomatic during at rest also and at exertional also. Such type are known as insignificant coronary artery disease. I repeat, anything blockages which is less than equal to, so this is the coronary artery, friends, and the blockages is shown. If there is blockage of is less than 50% cross section, the such patients are asymptomatic, right, both during the rest and during exertional. Such type of coronary artery disease are said as an insignificant coronary artery disease. Next comes is if the blockage is somewhere between 50% to 70%. 50% to 70%. If the blockage is between 50% to 70%, please pay attention. This is a very important concept I am saying. If the blockage is between 50% to 70%, such type of blockages, if happens, the patient is symptomatic at exertion but asymptomatic at rest. So when the patient runs fast or exertional, if it happens, such type of is known as a stable angina, also known as stable ischemic heart disease, ISD. Stable ischemic heart disease or stable coronary artery disease. Okay, remember, such patients will only have symptoms at exertional, not at rest. That means such patients are to be called as a stable angina. Mark this very important thing. These are to be treated symptomatically. Okay, so for such patients, of course, the symptomatic treatment is first you should treat it with the maximum. Of course, aspirin and statins are the must for such patients. Statins are the must for such patients, friends. And second very important thing is, okay, short acting nitrates plus beta blockers. Okay, so these are the drug of choices for the stable angina. I repeat, for stable angina or stable ischemic heart disease, one, when the blockages are between 50 to 70% occluding is present, such patients, if you do have, so such patients, stable angina or stable ischemic heart disease, stable coronary artery disease, the drug of choice for them is of course aspirin plus statin. Statin either atorvastatin, rosuvastatin, simvastatin, you can have that. And next is the nitrate, short acting nitrates beta blockers. I'll come back to it again, the treatment and management of stable ischemic heart disease, stable coronary artery disease. Now let's study the very important thing. If the blockages are more than equal to 70%, if the blockages are more than equal to 70%, okay, more than equal to 70%, okay, so you may have a blockage somewhere between 70 to 95%, and this is almost more than equal to 90%. So anything blockages between more than equal to 70%, okay, such patients, okay, please concentrate, such patients are to be called as an acute coronary syndrome. I label it again, acute coronary syndrome. Why it is called as an acute coronary syndrome? Because such patients will have symptomatic for angina symptoms both during rest and during exertional. So very important thing, such patients, those who are having blockages between 70%, see, look at this blockage I have shown here. Here is around 70%, here is going about 90-95%, anything which is more than equal to 95 to 100%. Such things are very important to be labeled, because such patients will start having symptoms at rest or during the exertional, and they will worsen. So such patients, if they do fulfill the criteria of that is rest angina, rest chest pain more than 20 minutes, very important, more than equal to 20 minutes. Number 2, the chest pain is increasing in the nature, it is never decreasing, that is crescendo in the nature, crescendo in nature, it is worsening only, it is increasing. At 7 a.m. you started to have chest pain, at 8 p.m. it is again worsening, at 10 a.m. it is again worsening, at 12 p.m. it is again worsening. So it increasing trend, increasing severity is known as crescendo in the nature, and of new onset and new variety. If all these three things are matched, okay, they are labeled as an acute coronary syndrome. Mark my words, acute coronary syndrome. Okay, so again I repeat, friends, very important thing to remember. So what is the important? So anything blockages less than 50% are known as insignificant coronary artery disease. Why? Because they are asymptomatic coronary artery disease, because they are asymptomatic during the rest or during the exertional. If the blockage is between 50 to 70%, they are known as symptomatic only during the exertional. That means you are climbing the staircase, you are walking very fast, you are carrying heavy lifts or something you are doing, at that time only you will have a chest pain. So such patients, if they are symptomatic and exertional, they are known as exertional angina, but such patients do not have pain at the rest, they are known as stable angina or stable ischemic heart disease or stable coronary artery disease. The treatment for them is basically aspirin, and you need to give statins for such patients, but the very important, to relieve the chest pain, you have to give short acting nitrates plus beta blockers, is very important, and then further you can add, which I will discuss later on. However, if the blockage is more than 70% and the patient comes to your clinic who complains of rest angina having more than 20 minutes and it is crescendo in the nature. It's worsening, and it is of new onset, as if he has not experienced such type of chest pain in the past. It is always a new variety and more of difficulty and more severity. If three things are matched, it is to be labeled as an acute coronary syndrome. Remember, acute coronary syndrome is symptomatic at rest, which means it has an emergency as need to be admitted for that. So remember, for 7, if it is the blockage is between the 95 to 100%, it is to be labeled as an ST segment elevation myocardial infarction. Okay, that was because in the ECG you will get ST elevations. Okay, why it is to be labeled as an ST segment elevation myocardial infarction? Again, I repeat it, friends. Anything blockages which is more than 95% to 100% if it is present, okay, the ECG will surely show then ST elevations. Why it will show ST elevations? Because remember, if you have got this as an left ventricle muscle mass, this is left ventricle cavity and this is the left ventricle muscle, okay, myocardium muscle, transmural. So when you have got a coronary artery which is supplying to this muscle, okay, and it is completely blocked, there is no blood supply happening to this part. So what will happen to this? There will be transmural ischemia will be developed. Transmural ischemia would be developed. This part, transmural ischemia would be present. So complete transmural ischemia. Transmural ischemia. That means whenever the coronary artery is blocked more than 95% to 100%, it is sufficient to cause whole thickness. Whole thickness is ischemic. This is known as an ST segment elevation myocardial infarction. Old terminology was Q wave myocardial infarction, because transmural, whenever it happens, you will get ST elevation on the ECG. ST elevation on the ECG. P wave, this is R wave, and you can see this is ST elevation which is elevated above. So you start to get on the ECG ST elevations. So this is very important. So that is the reason I was explaining anything block which is more than 95 to 100 plus, it is known as ST segment elevation myocardial infarction. Remember, your troponin I and CPK MB will be raised. Okay, why it will be raised? Because this is a transmural ischemia. It is a transmural, and transmural ischemia leads to the damaged necrosis of the muscles if it is more than 20 minutes, and this muscles damaged necrosis will release the enzymes inside it which are under cardiac troponin T or I and CPK MB level, creatine phosphokinase levels. It will release from the heart muscles and they will come into the circulation. That's the reason their levels will increase in our this thing. If there is a 70 to 95% block, that is subtotal occlusion, as 95 to 100% means it is total occlusion. You can see completely total occlusion has occurred. So total complete occlusion will lead to ST segment elevation. If it is between 70 to 95%, it is called as a subtotal occlusion of coronary artery. Subtotal occlusion is a common sense we can understand. They can present with if either unstable angina or non-ST segment elevation myocardial infarction. Remember, in both this condition, the STs are not elevated. Let me make it very clear to all of you, friends. This is subtotal occlusion. If it whatever is present, 70 to 95%, here it is labeled as a non-ST segment elevation acute coronary syndrome, which consists of two parts: unstable angina and non-ST segment elevation myocardial infarction. In between this, only the difference is that in unstable angina, the enzymes would be normal. That is CPK MB and troponin I. Okay, both will be normal. Okay, while in case of non-ST segment elevation myocardial infarction, friends, yes, the enzymes would be increased. Okay, so this will be CPK MB and troponin I would be increased. Okay, so this will be increased. Unstable angina, enzymes are increased. So only difference between the unstable angina, non-ST segment elevation myocardial infarction is that about. In unstable angina, the enzymes would be normal, while non-ST segment elevation myocardial infarction, the CPK, MB or troponin I levels would be increased. So this is a very, very important concept one should understand. Remember friends, remember the cardiac biomarker of choice. Cardiac marker of choice nowadays is whether it is fresh MI, whether it is recurrent MI. I repeat and say it, whether it is fresh MI or it is a recurrent MI, always it is none other than HS, cardiac troponin I. Quantitative levels, I repeat, highly specific. Specific cardiac troponin I. So this is very important, remember. Okay, so this is the marker, cardiac marker of choice for acute coronary syndrome is HS-C reactive. No more CPK, MBs are used nowadays. They are not that good markers, but remember HS-C reactive protein is a very HS highly specific or heart specific. It is also known as heart specific cardiac troponin I. So these are the two important things that one should label and one should understand into this. So is that so clear about that, friends? So I again label about this thing is about the coronary artery disease. Let me make it very clear again, friends. So let revise. You have a little complex things but very simple to understand. So let us see, after studying what is a coronary artery disease, the coronary artery disease can be divided into two parts. It can be either ischemic heart disease or also known as coronary artery disease, and another is coronary artery disease, which can be further divided into obstructive coronary artery disease and non-obstructive coronary artery disease. Non-obstructive coronary artery disease is basically a microvascular blockages, that is small vessels, not the epicardial vessels. Believe me, LAD, circumflex, left main coronary artery, diagonal artery, obtuse margin, whatever the arteries you have seen, we have studied till now, it is the epicardial artery which is naked with our eyes. So these are the one of the very important thing, and one which we cannot see and which are percolating or penetrating the myocardium of the heart. Those are known as the microcirculation or resistant vessels. So now we study the obstructive coronary artery, means the main coronary artery is either LAD, right coronary artery, or circumflex artery, or left mains coronary artery if it is there. So with that blockage is if happened, if the blockage is less than 50%, it is called as asymptomatic coronary artery disease. Also since because they are at rest also, at exertional also, that's sufficient enough to supply the blood. However, if it is between 50 to 70%, it is known as symptomatic at exertional and asymptomatic at the rest. Such are labeled as an stable angina or stable ischemic heart disease. While those which are this treatment is aspirin and statins, and that is the reason, friends, this is very important to understand. The beta blocker and short acting nitrates are very important for symptomatic relief. Let us come and study once if the blockages are more than equal to 70%. If the blockages is more than equal to 70% and patient fulfills the criteria of rest angina more than 20 minutes, crescendo in the nature, new onset and of new variety if it is present, then such things are known as acute coronary syndrome. Acute coronary syndrome, if it is more than 95 to 100% block, it is ST segment elevation myocardial infarction. ECG will surely show ST elevation. Okay, and if the blockage is between 70 to 95%, that is subtotal occlusion, the ECGs won't shows any ST elevation. That is why it is labeled as a non-ST segment elevation acute coronary syndrome. I repeat, non-ST segment elevation acute coronary syndrome, which includes unstable angina or non-ST segment elevation myocardial infarction. The difference between unstable angina and non-ST segment elevation myocardial infarction is that in unstable angina, the enzymes levels are raised. That is CPK, MB and troponin I levels are raised. while in the non-ST segment elevation myocardial infarction, the CPK-MB and troponin levels, in unstable angina, the enzyme levels are normal. Okay, please rectify this. The unstable angina, it is normal, while in a non-ST segment elevation myocardial infarction, it is raised. Remember, now the cardiac biomarker of choice for any acute coronary syndrome is none other than HSC reactive, HS cardiac troponin I, that is highly specific cardiac troponin I. Okay, so this is a very important thing that one should make a note about it. Is that so clear, friends, everyone? Okay, now let us see this beautiful video. This video will demonstrate how the coronary artery blockage is keeping into this mind of whole of the system, and let us see to this. Okay, so you can see our heart has got three important coronary arteries. What are these three important coronary arteries? The left anterior descending artery, the circumflex artery, and the right coronary artery. Among this, the very important is the left anterior descending artery, which is shown here. And the left anterior descending arteries, you can see that you will have these yellow color molecules which are seen are low density lipoprotein, that is a bad cholesterol. Since the age of 20 years, it starts to get deposit in our heart medial part, that is the intima and the media part. This is yellow color which is shown here, is shown as an atherosclerotic plaque, friends. This is what is the stenosis or blockages, what we call. Till 50% the patient do not have the symptoms. Okay, however, if this blockage increases from 50 to 70%, you will have myocardial ischemia with exertional angina, and this is known as stable angina. Okay, only during exertion, not during rest. Such patient with uncontrolled hypertension, diabetes will have acute rupture of this atherosclerotic plaque. Acute rupture of this atherosclerotic plaque will expose the lipid contents to the coagulation system. It will activate it. It will attract more platelet in the circulation, and thus this blockage after 70% is called as an acute coronary syndrome, because it consists of either unstable angina or non-ST segment elevation. This both condition are at the rest, you will get an angina. As soon as slowly you go, that is what is the worsening. If the patient doesn't come, the 95% to 100% blockage will happen, and at this blockage, friends, the total coronary artery will get blocked, and thus the patients will have an ST segment elevation as shown here in this video and the ECG. So coronary artery getting blocked 100%. So in nutshell, the coronary artery disease can be divided as an very important thing. One is obstructive, that is asymptomatic from 50% blockage, while if it is between 50 to 70%, it is known as symptomatic coronary artery disease, in which there is a stable angina. Okay, if the block is less than 50%, it is labeled as an asymptomatic. 50 to 70% is stable angina. Anything which is more than equal to 70%, it is labeled as an acute coronary syndrome. It is labeled as an acute coronary syndrome. So acute coronary syndrome, if the blockages is between 70 to 95% and the enzymes are normal, then it is labeled as an unstable angina. However, if the blockage is between 70 to 90% but the enzymes are raised, it is elevated, then it is to be called as a non-ST segment elevation myocardial infarction. However, if the blockage is more than 95% to 100%, then you will have an ST segment elevation myocardial infarction. Remember, this acute coronary syndrome but is because of the acute plaque rupture and the acute thrombosis, which is shown here. Is that so clear, friends? So this is a very, very important concept that one should understand, this coronary artery disease. Okay, yeah.